Hello, my name is Robert Demircioglu. I am doing a presentation on case number 4. This is a case where a 45-year-old male has a history with hypertension, however is not taking any meds to control it. He started having double vision 3 days ago alongside with a headache. On examination, he has ptosis of the left eye, dilation of the left pupil, and the eye is displaced down and out. This looks like an aneurysm of the left PCA, which caused some damage to his left oculomotor nerve. There is a saying, LR6, SO4, and the rest is 3. The oculomotor nerve starts at the oculomotor nucleus. From there it goes through the cavernous sinus and innervates with the levator papillae, superior rector muscle, inferior oblique, and inferior rectus, and the ciliary ganglion. The oculomotor nerve is responsible for the sphincter muscle, iris, and ciliary muscle, which is a muscle that plays a role in accommodation. However, to control these muscles, the pathway starts from the Edinger-Westphal nucleus, which is a preganglionic nucleus that contains parasympathetic fibers of the oculomotor nerve, which innervate the sphincter muscle and the ciliary muscle. The reason why the eye will move to the out and down position is because with the lack of the oculomotor nerve function, the superior oblique muscle and the lateral rectus muscles are still contracting, and since there is no resistance from any other muscles of the eye, it will move to the out and down position. The circle of Willis is a vascular circuit formed by the anastomosis between branches of the internal carotid arteries and the vertebral arteries around the optic chiasm and pituitary stalk. It consists of paired internal carotid arteries, anterior cerebral arteries, and posterior arteries. It has two anastomoses, one at the anterior communicating artery and another at the posterior communicating artery. The functional significance is that this circuit provides alternative channels to bypass a potential site of vascular occlusion. It also equalizes the arterial flow to both cerebral hemispheres. Now I will show you the relationship between a part of the circle of Willis and the oculomotor nerve. So over here we can zoom in into the PCA. And notice how if there would be an aneurysm of the PCA, it would affect the left oculomotor nerve in this case, which can cause damage, thus presenting how the patient presented with the down and out position. So what is the cause of coloboma iridis and what is the development of the optic cup? So I'll start with the optic cup first. The development takes place between 3rd and the 10th week of the fetus. The optic cup is a central depression located in the middle of the optic disc. Optic grooves arise from the neural fold and develop into optic vesicles only after closure of the neural tube. Optic vesicles induce changes in the surface ectoderm, and this starts to form the lens placode, which is an embryonic structure that consists of a thickening of ectoderm. This ultimately develops into the lens. Lens placode invaginates, giving rise to the lens pit. Simultaneously, optic vesicles begin to invaginate and form the optic cup. The optic cup has a central groove called the choroidal fissure, which allows entrance of the blood vessels that supply the eye. So what is the cause of coloboma iridis? Coloboma iridis is a unilateral or a bilateral developmental disorder of the eye in which the choroidal fissure fails to close by the 7th week of development. It can be a defect in one of the structures of the eye, for example, the retina, the optic disc, or the iris. Describe the histology of the retina. So the retina consists of the retinal pigment epithelium and the nerve layer. The nerve layer, also referred to as neural retina, is further subdivided into 9 layers, each containing specific cells. Most prominently, the nerve layer contains the first, photoreceptors, the second, bipolar cells, and third, ganglion cells, neurons of the visual pathway. Let me show you a better picture of this histological section. So we're going to go from top to bottom, which is outside in. You have the extraocular muscles and the connective tissue in white. You have the sclera in purple, the choroid in red, and the pigmented epithelium in dark red. Now we'll get into the finer details of the retina. You have the retinal pigmented epithelium, the layers of the rods and cones, the outer nuclear layer, the outer plexiform layer, the inner nuclear layer, the inner plexiform layer, the ganglion neural layer, the nerve fiber layer, and then finally you have the posterior chamber, which is in white. So explain papilledema with picture. Papilledema is the swelling of the optic disc due to elevated intracranial pressure. It is a hypertensive emergency. It is usually asymptomatic, but it can still present with loss of visual acuity due to enlargement of blind spots. This picture is a fundoscopy of a 43-year-old patient with visual impairment due to intracranial hypertension. The left side shows the characteristic fundoscopic finding of papilledema prior to treatment. We can see obscured disc margins with venous stenosis and small hemorrhage. And the right image shows the resolution of papilledema after treatment. Next question is, why is there aneurysm of large vessels aorta in Marfan syndrome than small vessels? So Marfan syndrome is a mutation of fibrillin 1 gene, short form is FBN1, on chromosome 15. It causes defective connective tissues with microfibrils and defective elastin. It causes more problems in larger vessels like the aorta compared to smaller blood vessels because the larger blood vessels have more elastin. Let me show you a histological representation of the two so you can get a better idea of why the aorta in this case is more affected in this disease process. So we're going to start with the smaller arteries. We're going to go from inner to outer. We can start with the lumen, which is in brown and white, the tunica intima, which are loose connective tissues, the internal elastic lamina, the tunica media, which is a ring of smooth muscle cells, it's in dark pink, and external elastic lamina externa. Then finally you have the tunica adventitia. Notice the size of the elastic lamina externa in dark purple when we compare it to the larger arteries. So the tunica adventitia of the aorta is mainly composed of fat with connective tissues. And then there is the media. And because the aorta is an elastic artery, its media contains mainly concentric elastic fibers with few interjacent layers of smooth muscle. The aorta wall distends during systole and rebounds during diastole in order to attenuate the fluctuation of the blood pressure, and this is where the elastic fibers come in handy. What this ultimately means in Marfan syndrome is that if there is a problem with elastin, then there will be no rebound and therefore have problems in the diastolic phase and may not be able to perfuse the heart properly. This can also mean that if there is no rebound, then it can stretch and cause an aneurysm or worse, a rupture. Next question is, describe how urecycle defects cause encephalopathy. Encephalopathy is caused by hyperammonemia because of liver damage due to no ammonia detoxification. In severe cases, this can lead to metabolic encephalopathy with coma and death. Let's look at the pathophysiology of it. So over here you have you will have a defect in the enzyme ornithine transcarbamylase. It can cause an impaired conversion of carbamyl phosphate and ornithine to citrulline and phosphate. Ammonia cannot be eliminated and accumulates, thus causing hyperammonemia, which thus causes ammonia toxicity, and then that can also lead to metabolic encephalopathy. These are my references. Thank you for listening and have a good day.